Hello, respected viewers and followers of Jungle Online TV. You're watching us from the side of the Wakera Jungle Conference Hall, where we came to attend the Gambia International Social Protection Conference on the theme Investing in Resilience Towards Long-Term Financing on Social Protection. Yesterday was day one where we had important discussions with people from different countries. It was really an interesting session, and today brings us to day two, where we will also have important discussions with people from different countries as well. I will take you through the day two activity. There is the first one is from 8 to 8:45, there will be breakfast, and then from 8:45 to 8:50 is a recap of day one by the moderator. Then that takes us to the other plenary one, that is from 8:50 to 9:50 by this, which is social protection of human development, financing long-term resilience in Africa, and the presenter was Aminata Bokum Traore, African Development Bank Group. Then we moved to the second plenary where we had disaster risk financing case of study, the Gambia. That was done by Maudo Abdullahi Jaro, National Disaster Management Agency, the Gambia. Then we moved to the third plenary that was done by Dr. Anna Hilda, Senior Economics World Bank, and Mr. Malik Jai, Deputy Country Director, and the topic was on adaptive social protection design and implementation opportunities and challenges in moving to scale. Then from 11:50 to 12:30, we had a coffee break. After the coffee break, we returned back to our respective positions. That brings us to the fourth plenary, where we discuss the refined classification of household income base on PMT data, a case study from Kenya. And the presenter was Tobin Fister, Regional Director, ID Inside Dakar. Then from 1:30 to 2:30, we had the fifth plenary, that is revolutionization of social protection delivery through mobile money, a Kenyan country case study representation. And the presenter was Peter Ombasa, Senior Social Protection Specialist from Kenya. And from there, we had a lunch break, and that was from 2:30 to 3:30. After the lunch break, we returned back to our respective positions again to continue with a parallel breakout section. On this one, there was two sections. There was section A and section B. On section A, the discussion was on health insurance towards universal health coverage, and on section B, the discussion was centered on gender, children, and disability inclusive social protection. And the plenaries were Jibril Jaju, insurance provider, Director National Health Insurance Scheme, Edward Francis Northgate Hospital. The presentation was done by Jibril Jaju, Director of Planning and Information. Then on this second session, the presentation was done by UNFPA. The panelists were UNICEF, UNFPA, MOGSCW, and then Gambia Federation of this for the disabled. This brings us to the end of day two, and this will be the activities we'll be having. So do join us on this wonderful platform to have an insight of what we'll be doing there.
Apologies for the delayed start. I'd like to welcome you all to day two of the Gambia International Social Protection Conference. Day one yesterday was the opening ceremony, and we had a couple of very interesting plenary discussions. And for day two today, we'll be heading into very technical discussions as well. So our first presentation for today would focus on social protection for human development, financing long-term resilience in Africa. Now this is very important because, as you can see, the theme for this year's conference is investing in resilience towards long-term financing for social protection. And so I believe that aligns perfectly with this topic. And this, we will have a very expert presentation by Aminata Traore. She works for the African Development Bank Group. She was actually meant to be here with us in person, but due to certain reasons beyond her control, she cannot. So she'll be joining us virtually. And so because of that, we are slightly behind time, so we'll jump right into that. So if you do have questions, please just note them down. And because of time, we would limit it to one question per person, and we will take at least 3 questions per presentation. Okay? So thank you very much. Musa, I believe Aminata can share her screen and she can start now.
Hello, Aminata.
Yes, hi Sam. I can hear you now.
Okay, so you can share your screen and begin now.
Okay. Let me do that. Can you see my screen? Okay. Let's start. Okay. So good morning, everyone. It is an honor for me to join you today at this conference. Unfortunately, I could not be in person, but I am delighted to join you virtually and share a few reflections on the theme Social Protection for Human Development, Financing Long-Term Resilience in Africa.
So, maybe I will give the opportunity for Anna to present herself, and after we move to the presentation, you can go to the first one. And over to you.
Thank you, Malik. Good morning, colleagues. I'm very excited to be here. Sad to be here virtually, but I'm very excited that today's times do allow me to participate, and I'm looking forward to an exciting presentation and program. Thank you, Malik. Back over to you.
Thank you. So the presentation will cover different aspects. I will talk about the context of the Gambia, the way we are concretely with regard to adaptive social protection, and I will give some example of adaptive and definition of the adaptive social protection and example of impact in other countries. And the third point will cover adaptive social protection as an efficient and cost-effective tool and the public financing opportunities. Myself, I will cover the 2 points. The first one, the 2 point on context and definition, and Anne will cover the cost effectiveness of the adaptive social protection and as well the public finance opportunities. Let's go to the next one. So, as you know and already presented in the previous presentation, Gambia is very exposed to shocks like drought, dry spell, floods, and it affects really vulnerable population, low income, and it creates situation where they have livelihood erosion. So the adaptive social protection is now come here to really to resolve some situation that these groups are facing. It integrates disaster risk financing management and help really to anticipate. When we talk about anticipate, meaning before a shock arrives, and during the shock, it helps household to absorb and as well to adapt to the situation. Now, adaptive social protection is quite important tool because it really creates a new feature in the way we deal with shock. Instead of being reactive to shock, if I take the case of WFP and DMA, we have been working a lot in responding to disaster here in the Gambia. Windstorm during the COVID-19, as well the drought in 2023. So, but when you have a ISP that works very well, it helps really to anticipate the response, to make the to put in place anticipatory action, and to support ahead, household during the crisis. And we have seen the impact in terms of human capital, as well preventing to deterioration of the poverty, and really supporting household to fall into chronic cycle of vulnerability. So the context of the Gambia is quite interesting in terms of adaptive social protection. A lot of effort. We have the early warning system now, contingency planning, in place. NDMA is really working hard to make sure that there is an active and operational contingency planning. Those elements create the opportunities to have, you know, an operationalized adaptive social protection. So when it's well designed, you know, and we have the resources in place, it helps really as well to reduce the burden on fiscal pressure. We have situations where when there is a disaster, for example, the disaster occurs, we have the impact, the information, thanks to the early warning system that we have in place and the data we have been collecting, thanks to the NDMA staff in the field. It's now when we start, you know, preparing, looking for resources to respond to the population. And you know, when it's very late, the situation, you know, deteriorate, and the impact that we are looking at, most of the time we don't have it. And you'll see in the presentation where when you are well ahead of, you know, mobilizing resources before the response or before the shock arrives, and when you respond, you minimize the impact of the shock on the household. Can you move to the next one? So I will talk about the definition. And the definition, the first thing is adaptive social protection helps to strengthen the resilience of poor and vulnerable households. And it helps as well, you know, to enhance the capacity to prepare, you know. The preparation is quite important, and as well, coping, they will help household to cope and to recover from adverse, you know, events. So, and the adaptive social protection integrates the social protection and as well the adaptation and the disaster risk reduction. Can you move to the next one? So, and you need different kind of feature in the adaptive social protection. The first one is the shock responsive aspect of the adaptive social protection. So maybe when you have it well designed, it helps you really to respond quickly and to predict when disaster, you know, or crisis occur. It needs to be risk informed, meaning you have a data to inform your system. The early warning system helps you to know when the likelihood to have, for example, floods, for example, in a given space, and the data that you are collecting. For example, in the Gambia, we have been doing every year a national food security survey. It helps really to do a profiling of the household that are vulnerable to crisis, that are exposed to shock. It helps really to anticipate knowing the profile. And another very important feature that I have not mentioned here is having as well, you know, the information on poverty, like the social registry. So the flexibility to deliver is very important, a very important element of the adaptive social protection. When there is a shock, for example, if I can take a case, for example, the NAFA program, which is providing support to poor household, and when there is a shock, you can, in a given area where you have beneficiaries of the program affected by the shock, you can decide to provide a top-up, for example. It will be very fast and quick, and as well at the same time you can expand, meaning you add new beneficiaries, you know, in the same location, using the same payment system. So, and another important feature is it needs to be integrated. So, meaning you combine cash transfer with insurance, economic inclusion. The cash transfer as well program, very important. Actually, we have been implementing a project with the Ministry of Environment and several government partners. We'll talk about that. You know, where we have a combination of different features, providing cash transfer to beneficiaries that are involved in some food for asset, what we call activities, and providing insurance to farmers, meaning farmers will pay premium to be covered. If there is a problem, they will get, you know, covered, like what you are doing with your car if there is an accident. And this is something that we have been working on, but with Lukai, a lot of work that we have been doing with the Minister of, with the Central Bank of the Gambia, creating the environment, because the micro insurance companies, they are not used to that. It's a very new domain here in the Gambia. So, and working as well with our neighborhood Senegal, bringing experts here, because it has been there for a few years. So economic inclusion, and that program as well have some economic inclusion where we support women with income generating activities. And all this, package combined with disaster risk management and climate adaptation measure. And in terms of adaptation as well, Fodi will talk about that, looking at the priorities of the communities, what they need really to adapt to the current situation, and we provide them support, because it's coming from, really from them. Now you can move to the next one. So here we would like to show different scenarios where you have household that, receive coverage and household without coverage. What we have observed is that before the shock, even the household with coverage, they are in a better situation in terms of welfare. When there is a shock, they will, and it covers really the different aspects of the adaptive social protection. The anticipation, it's before the shock arrives, and the absorptive capacity. When there is the shock, you see the impact on household with coverage is really lower. And when after the shock, the adaptive capacity is even higher among households with coverage. So it helps really equip them, and to withstand future shock. Meaning when there is a shock coming in, they are in a better situation. And the different intervention that we have here in the social safety net program, the safety net program that like the NAFA one, the economic inclusion intervention. You have a lot of, I think, economic inclusion with even the Ministry of Gender, and the shock responsive program. We are responding to shock. But now when you have all these features together, and I will come back to again to at some point regarding the implication when you have them all together, and the cost efficiency, the impact, and even limiting duplication of the different effort. In the Gambia, I can say we are quite good in terms of, when you have all these programs, but not very well integrated, and the risk of overlap is very high. In some area, you can have beneficiaries that receive social safety net program. At the same time, the risk of as well being targeted to receive economic inclusion program is there. And the shock response, when there is a shock, WFP with NDMA will come again. And we don't have the data to compare, to see who is receiving what. That's why even the relevance of having this type of approach here in the Gambia. So please, can we move to the next one? So, and we have seen the impact of adaptive social protection in a lot of countries, in West Africa, in the Sahel countries, in Burkina Faso, in Senegal, in Mauritania, and the impact to cover different area. It first impacted the poorest and the most vulnerable, and at the same time it covered, it contribute to the country different level as well. If you look at the impact on the poorest household, for the case of Senegal, for example, evidence show really that social safety net, reduce, extreme poverty. And in Chad, the same findings as well. In terms of resilience, the productivity as well, we have seen those evidence. If you look at the country level, the local economy, the society, we have seen, for example, in Mauritania, social safety net participants, engage significantly, in social support. So, it's really huge in terms. This has been evidence in these countries, from different studies, World Bank and other partners. So it's not only giving support to the beneficiary, but as well to the communities and the countries. So can we go to the next one? So, and my colleague, and we'll talk about how efficient adaptive social protection, efficient and cost effective is adaptive social protection. So, Anne, over to you.
Thank you very much, Malik. I do hope you can hear me well. If not, please signal to me. So I'm going to walk through how adaptive social protection and setting up a proper adaptive social protection system makes sense, because it is both efficient as well as cost effective. And I will provide 3 examples of the efficiency and cost effectiveness of an adaptive social protection system, which are related to targeting the payment system and the reduction of over-reliance on humanitarian responses. But first, if you could go to the next slide, I'm going to walk through the building blocks of an adaptive social protection system. What do we mean by an adaptive social protection system? So my colleague has already started introducing the elements of it, including that it integrates multiple different disciplines and that it focuses on also anticipatory action to prepare for a shock before it can happen. The building blocks of a social protection system that we usually look at are 4: data and information, programs, institutional arrangement and partnerships, and finance. I'm going to walk through briefly through each of those blocks to better explain what we mean by them. So starting at the top, data information, what we capture here are the registries, early warning systems, anything that is a system that's available on the ground that offers information on both populations, but also on climate shocks and events that are happening in the country, and enables the rapid identification and targeting of those most in need. Moving to the right, programs are the programs that are in place. Those include regular safety net program, national safety net programs. Those also include the additional programs like economic inclusion that help build the resilience of households before a shock even happens, so that they're better able to respond to it afterwards, to build resilience over time. And then shock responsive programs that really support the recovery after a shock has occurred. Institutional arrangement and partnerships, here, because adaptive social protection is so multi-sectoral, you've already seen this in this presentation, but also in Malika's presentation earlier, it touches on issues of disaster risk financing, disaster risk management. There's a lot in there, so proper coordination and leadership is really important to coordinate all the different agencies and ministries that are involved in the planning and in the response. And finally, financing. This is one of the key topics of this conference, and particularly for adaptive social protection. As for social protection in general, it is important to have predictable financing available over time. In the case of adaptive social protection, to have pre-arranged financing instruments or contingency funds that enable a rapid response and mobilization in case a shock hits. On the next slide, I will now apply this to the Gambia to give an overview of the current status of the adaptive social protection system in the Gambia from Malik and my perspective. So starting again on the top of walking through data and information, we noticed that the Gambia actually has a universal social registry covering the entire territory and population, with one of the, or I believe actually the highest population coverages in sub-Saharan Africa. That is a great achievement. However, it remains a static registry. It does not currently involve information updating over time. There is no link to the early warning system. There's no current link to the climate data. On the positive side, it is widely used by government NGOs, international partners. We're given examples here, but it is not currently interoperable with any of the partner systems. The early warning system, the other part of information and data, the information data building block remains rather fragmented. There are several early warning systems in place. Continuing with the program section, there is a safety net program, the NAFA program, that I'm sure has come up several times during this conference, which has large coverage. It will, starting November, will have covered 30 out of the 43 districts of the countries at least once. However, it is not established as a national safety net program. It is currently project and donor financed, and it remains up to date, mostly a manual payment, though there are goals to shift towards digital payments. A productive economic inclusion pilot is starting as we speak, or has started as we speak in 3 districts of the country, but it does not have any form of national coverage today, and there is no shock response program that is a reliable program. The response so far has been mostly ad hoc. For example, NAFA-Quick during COVID, the response to the Coney crisis. These are programs that are being developed or responses that are being developed as the shock already hits. In terms of coordination, the coordination framework, we do know that it remains siloed at times and that there's a need to strengthen the cross-ministerial coordination. We think that the new social protection policy that is under development could be a driving tool to strengthen these multi-sectoral partnerships, as well as the coordinating role of the National Social Protection Agency, who's the coordinating body for the sector. Finally, moving to financing, we notice that there's currently financing instruments that remain largely ad hoc. There is no functioning contingency fund. There is one sovereign insurance mechanism, ARC, for drive insurances, but it only covers one out of the main 3 hazards that affect the country. So there are large rooms for improvement and for strengthening the adaptive social protection system in the Gambia further. And over the next slides, I will move to 3 topics in more detail: the social registry, thereafter the payment system, and thereafter the humanitarian response, to look specifically at the opportunities for the Gambia. Social registries, as I think a lot of us in the room know, are an efficient way of improving the accuracy and the response time of targeting and reduce costs. They make targeting more progressive and equitable. If they're being used by multiple programs, as is the case in the Gambia, they reduce overall costs and maximize impact, because it is possible to coordinate between complementary programs by having one database of beneficiaries and potential beneficiaries. The Gambia has made important strides over the last years to develop its GAMASAR, the Gambia Social Registry, which is one of the most comprehensive social registries that I've seen. However, it is important now to use the momentum and start shifting it from a static registry that captures information at one point in time to a dynamic registry that is able to update information as updates become available, including both on-demand updates, but also updates through interoperability to other systems. The local area councils, I heard a gentleman interview earlier, could be employed to promote local data validation when updates come in, or other the concentrated agents of the state, whenever updates come in, to do a first check of verification to set up a system that is truly dynamic. Interoperability, particularly with the early warning system, but also other databases, for example, the ID databases, it needs to be strengthened. The database is currently not interoperable, and climate and vulnerability indicators need to be integrated to properly enable anticipatory action, because it will allow proper planning and knowing where hotspots for certain events are, and which beneficiary, which households might be affected, which areas might be affected, to then start the response planning. On the next slide, I'm going to give an example of the payment system and of the importance of moving to a digital payment system, which will enhance the impact as well as the transparency of the transfers. Across the Sahel, we've seen that digital payments were on average cheaper than cash and hand transfers. We're given the example of Niger.
Including data science and machine learning. And what's important here is that we engage with our partners in a conversation about what is the right tool to use to answer the question at hand, and given the constraints that our partners face. So in the case of Kenya, this, for example, meant that we had to integrate in a very fast-paced policy cycle. Moving on then, the key research or the key question that I would like to be discussing today is something that builds a little bit on the conversation that we had yesterday around the importance of social registers, as well as the question around financing that I think we got into a lot of detail today. And I hope that this case study can provide some insights, in particular around using existing proxy mean test data, social registry data, to design an equitable contributory social insurance program. And I'll be using lots of visuals like this just to put this question in perspective. So ultimately, the goal of many of these social protection programs is to either determine eligibility for programs or to determine contribution amounts. And the way this is usually approached, we've been through this in several of the conversations, is to use existing household level data on expenditure, on assets, to then predict, to estimate a ranking of who are poor individuals that are particularly worth including in that particular program, and to sort of like use that ranking to target our programs. So what I will be talking about briefly is just bringing everyone on the same page with regards to how is proxy means testing used for eligibility purposes. So I plan to set the scene. Given this is a conference on social protection, many of us will be familiar with these concepts. We had a discussion before about inclusion, exclusion errors that also came up in the presentation just before. I just want to visually provide some examples of this to set the scene and to then think about how is this approach working out and what are the implications if we were to use a similar approach determining contribution amounts. So I think that will be helpful to have in mind. Before then moving into a case study, and I will give you a glimpse of how this worked out in this case study from Kenya, and I'm saying I will give you a glimpse very consciously because I'll keep that context fairly high level, given some contractual obligations, to like not speak about some of the details and some of the data. I'll still try to answer all of the questions that you have with regards to this, of course. I'll then speak about two brief model improvements that we introduced, where we collected additional data and we introduced an appeals mechanism that allowed us to really improve on equity and reduce some of the exclusion errors and misclassification, but I'll get into that. So moving into the sort of like recap, if you will, eligibility and targeting for eligibility usually means that there is a steep cutoff rate in the benefit. So if we, that hopefully doesn't come as a surprise, right? But eligibility criteria just mean that some percent of the population receives access to a program or a service while another part does not, and we need to determine sort of like those cutoff rates in a very equitable way. And I'm illustrating this just here for a hypothetical program where we're trying to target the poorest 20% of the population, here generated by the PMT score, like the proxy mean test score. So that sounds fairly easy, right, in theory. But remember that this PMT score, this ranking that we're using, is just an estimation. It doesn't necessarily reflect which of these households are actually worthwhile and vulnerable, but it might suffer from like inclusion and exclusion errors. And I will go through that visually a little bit. So, as I said, we actually do not know who the poorest 20% of the population in this example were. So what we oftentimes do in practice is that we're using information from the social register to then estimate a particular model. Usually it's some sort of like proxy mean test model, whether that's linear or otherwise, to come up with these rankings. And the information we're using is usually coming from expenditure asset data. There has been lots of progress in terms of refining what we collect. We heard already before, we had a lot of discussion yesterday as well on the Gambia social registry that being one of the most comprehensive, that having 100% coverage in the country, which is really critical, especially if we're talking about now the contributory schemes as well. So this is basically, just giving a sense of how these models work. And visually, what this looks like is basically illustrated in this graph. So what we see on the horizontal axis is, again, these predicted scores of wealth in the population, and the vertical line is indicating the poorest 20%. So everybody to the left of the vertical line is who we would like to include in the program according to our targeting exercise. And what the authors in this work did here is, this is an example from Rwanda, is to collect actual consumption data as well. So what we're plotting, in addition to the prediction on the horizontal axis, is the actual consumption ranking on the vertical axis. And then we're applying the same 20% cutoff to the actual consumption data, which means that everybody that's sort of below that 20% percentile on the vertical line should be actually covered according to the consumption data. So what this means now is that we're targeting some group of the population in the bottom left corner correctly, but we're also excluding a large part of the population. That's just by design in terms of how we're using a prediction to do the targeting. So the bottom right part is part of the population that is excluded by design, and then we're including a part of the population in the program to the left of this vertical line that actually, if we're looking at the actual consumption data, might not be eligible for the benefit. So these are the inclusion and exclusion errors that we talked about. This is a particular strong case, and I can't speak to the case of Gambia. I haven't worked or seen, looked at the data. The general point that I'm trying to make, though, is that across programs, there has been a lot of research on the extent of these inclusion and exclusion errors. And this is an example from Indonesia here, where stakeholders undertook, again, a really well-researched pilot targeting exercise to demonstrate the effectiveness of this proxy mean testing mechanism. I think this is taken from a document of the Australian aid agency that then assessed sort of the effectiveness of different programs. And what they found is that across the lowest 30% of households that were eligible, only about 50% or so were correctly targeted. So there's a massive gap in this segment of the population that is actually targeted by this transfer, by this cash transfer program. So now this is not to say that proxy means testing is all bad and that we're lost. That's not the point to say here. So as Anne said in the prior discussion, any targeting will have exclusion and inclusion errors, but it's really important to be aware of these dynamics. And again, I can't speak to the state of this problem, to the extent of this problem in the context of the Gambia. I haven't looked at the data, and probably even if I know this is a high-level conference, I wouldn't be saying it. But I think it's something to be aware of. And moreover, I think it's also important to mention that there have been various attempts to increase the precision of this targeting exercise. We spoke a lot about already participatory processes, getting community involvement to validate those rankings, as well as integrating appeals mechanisms. So there has been a lot that has been done in terms of reducing these errors, but from a purely technical perspective, which is often the perspective that we take in our work, we're trying to fit a very prescriptive model to very complex multidimensional data, and these errors will happen. Okay, so far, just for the setting the scene. What I would like to talk about now is basically how proxy means testing data could be used for determining contribution amounts in contributory social insurance schemes. So we go back maybe to the illustration that we had before. Here we go. Where we now talk about a contributory scheme where we require the richest 20% of the population to cover the full cost of the benefit, and then as a government subsidize the contributions for other parts of the population in different buckets, right? And this is just an illustrative example where we go down to having the poorest 20% of the population cover about 10% of the cost of the program, right? So this is another, just an illustration of this contributory scheme. So now, from a technical perspective, the question then becomes, how do we find out which income bucket or which income group a given individual falls into? And again, from a technical perspective, there's two ways to think about this. Where the first one is that we would like to estimate a precise income measure and then use that to like rank people in the categories. And the second one is that we would directly try to predict which of these categories a certain individual is in. So one is an estimation problem, the other one is a classification problem, and that's from a technical perspective, again, different models that we would be applying, and some of them might have advantages over others. So this is again just focusing on highlighting the importance of the model here for determining these contribution amounts. Now just a couple of points that I might have mentioned, right? We said these PMT models are typically used for targeting rather than as a ground truth measure of income. We also said that these models try to explain variation in consumption mostly in consumption. And these models generally are they're not perfect. No model is perfect, but some of these models have been shown to be particularly bad. And what I'm showing here is a graph for, it's from a somewhat dated document again, but that was assessing, again, the performance of these models across different countries in Rwanda and Bangladesh, Sri Lanka, Indonesia. And what we're seeing is these red dots. Again, those are the predictions that are coming from our PMT model. And in all of these contexts, a lot of resources have been invested in getting the actual consumption distribution. So that's the blue line that we're seeing. And what we're seeing across these contexts, what's really important to understand is that we're underestimating scores for higher income households. Yeah, so all of these dots are below the blue line on the right end of the graph, but we're overestimating the consumption for the poorest in the population. So that is just a technical conclusion. Again, it's a result from the model. But what this means is that for targeting work, this drawback doesn't necessarily affect our implementation, except for the inclusion and exclusion errors that we spoke about. But if we're thinking about a contributory scheme, there might very well be implementation problems because we're skewing the amounts that, in particular, the poorest parts of the population would have to pay, and we're inflating them. So from an equity perspective, we're disadvantaging those that we actually would like to support through the government subsidy of this program. So knowing this, therefore, in this case study that we're now going to move into, we were interested in what can we do to address this problem? How can we change the models and the underlying PMT approach to increase fairness and equity, in particular for the poorest of the poor? That was really the objective of our support. And with that context and theoretical underpinning, I would like to now move into the case study from Kenya. So again, I keep this high level, but happy to try and answer questions to the extent that I can. So the Kenyan Ministry of Health instituted a contributory social health insurance scheme that would include contributions from both the formal and informal sector households. And the plan for these contributions was to be proportional to the household income. For formal sector households, reported income is something that's known and therefore would be used. And for informal sector households, income was to be determined using this PMT model. In our role, we now supported the Ministry of Health in designing and implementing this model. And the ministry used a household budget survey data set that included information about income and other indicators to train the original model to do the PMT exercise. And our focus, as I said before, was in particular to increase equity for the poorest part of the population. And that meant thinking about how can we reduce the overestimation of income for low-income households in particular. And then we engaged in additional data collection exercises, focused on particular poverty pockets across the country, and I'll get into that a little bit more. And we also introduced a somewhat automated appeals mechanism using the data that was available to us. So again, we'll be looking at just the setup with this visual that you're already familiar with. So again, now the context is that the existing model that the Ministry of Health proposed to be used was a model that just was a single model for all income groups, one model for the population. So that meant that we would be using all the data available to us to use the same weight for all the information that we have and predict income levels. And these income levels would then be used to determine contribution amounts. So that was the initial idea, the initial approach. And that approach posed several methodological and also equity challenges. And those are listed here, and I want to go through that. So again, having one single model for all income groups, we already saw that, will very likely lead to the underestimation of high incomes and to the overestimation of low incomes. So there is a massive equity consideration here. But also using the same set of indicators for all income groups might not be the best choice because not all of these indicators might have the same informative value across different incomes. So if somebody owns a TV, if somebody owns, like a boda, if somebody owns a car, that is information that might be very different across income groups. The third aspect was that it also didn't allow us to disaggregate and look at model performance by income group. That is something that is very difficult to do if we have a single model, and therefore it also prevents us from making incremental improvements and updates to model performance when we're looking to improve equity. Okay, so based on this, what we did to overcome those challenges with the existing PMT model was to develop a two-step model that would first, in the first step, predict high-level income categories. So is somebody low income, middle income, or high income, right? So those are just like a general classification. And what we would then do is to develop group-specific models that, in a second step, would predict very granular income groups. So you could think about in the low income proportion, in the low income group, is a household earning maybe below $1,500 per month, between 1,500 and 3,000. So those are like very, very granular income groups. And those income groups could also then vary across these high-level categories. So for higher income categories, those intervals would be much larger. So that's basically the innovation that we did. Hope the visual is much clearer than all the code and all the data that goes into that. But that's the basic idea. And this really, I'll keep this short, allowed us to overcome several of the challenges that we spoke about. We now have multiple models that are allowing us to do separate model improvements, to incrementally look at performance, and to give different weight to different information for each of the groups. So that's very technical. I'll just go over that briefly, but importantly, it allows us to look at equity. because it allows us to focus on the group of low-income households that is most at risk to be disadvantaged by this approach. And second, it also allows us to inform the contestation, the appeals mechanism. So yeah, with that, maybe we can look at some of the results now. I think that's something that you've been waiting for. So what I want to say is that before interpreting the results here is that I am choosing to show you results for a part of the data set for which we know that all of the households are low income. Okay, so the goal really is that this bar on the left here for low income households, we know that that is 100%. That's the truth. Okay, so that's something that we did for the additional data we collected, and that's the cut of the data that I choose to present here. But what we see is that the original model that is here illustrated on the left bars in purple, that in the original model only about 18% of households were classified as low income, even though all of them were actually low income. And this is an artifact again of the model, because there was a large proportion of households in the middle income groups, so a lot of the model was biased towards that segment. What we then also see is that this updated two-step model that we developed produced a significant improvement. About 70% of the households are now correctly classified as low income, while we reduce overestimation for these middle income categories here. So we're massively reducing exclusion error in the targeting setting, if you will, but here we're basically categorizing on the higher level. Yeah? On the first sort of like step, low, medium, high income households, we're reducing misclassification, and therefore we'll get closer to the accurate amounts that should be paid for by these households. So while an improvement, still we're only at about 70%, and the goal is to get to 100%. So what we thought about is how can we get closer to 100%? And this is really where these model improvements come into play. So I'll briefly talk about what we did for those. So to further improve equity, we collected additional primary data. So that comes at a cost, of course, but it's a fairly small sample of about 2,000 households that we sampled across 8 counties in Kenya. We worked with the State Department for Social Protection to identify poverty pockets in those counties. So it's not a representative survey, because we wanted to really purposely sample low-income households to be able to further differentiate between low-income households. That's what we saw in the graphs before. You know, the curve is really flat. It's really difficult to further differentiate those households, and therefore we collect indicators that are similar to those included in the Kenya Integrated Budget Household Survey, a standardized survey that's conducted in regular amounts of time. But we also included additional indicators around occupational status and agricultural production, agricultural land. In addition, because we felt that that would allow us to differentiate these households in the low-income proportion further. So again, we had limited resources and time to conduct this, so there are certain things that are just out of scope. We didn't collect any nationally representative data, therefore we can't think about model performance overall, you know, for like medium and higher income groups, and also we're not able to look at very granular estimates of accuracy across income groups. So these are more technical aspects here, but that's the data collection that happened, and then the way we used this additional data was first to implement fine-tuning of the second stage model. And I'll show you that in a second visually again. But we identify indicators that provide better prediction results for this underrepresented population. That's the first one. Second one is that we can treat the model. We can drop uninformative indicators. Not all the indicators have the same information across these income groups. You know, in the higher income groups, for example, everybody would own a TV. Most would, you know, in the high income group would own a car. So that information, you know, might not be relevant for the second stage models. We can really tweak those models to be more specific. We would also be able to change model predictions post hoc, so afterwards we could sort of make specific changes to better reflect what we see in the ground truthing. And then we can sort of predict with the additional data how well is our model performing. And therefore we can get a sense of how well would it be performing if we were to roll it out to the general population. So again, it's an additional investment in resources, but our hopes were really that we were able to increase equity with those efforts. So visually now, what I said is that we focus in particular on the low-income segment of the population. So these model refinements and post-hoc corrections, they're really just for the second stage model that I spoke about. And also the appeals mechanism that we introduced is only for the low-income household group. So this appeals mechanism allows us to build in predictions about how certain we are that a given individual falls in a given income category. So am I earning below $2,000 a month or between 2,000 and 5,000? We can have an estimate of like how certain we are about those categories. And if a person then appeals, they need to provide additional information, and the information that the individual provides, in addition to the information we already have and the certainty that we have, allows us to somewhat automate this appeals mechanism. And maybe then looking at the results of those two additional model improvements, we again, so like take this step back, we know we want to get to 100%, right? That's the goal. So in green, that's the third bar. On the left, we see that we're now going from about 70% of households classified correctly to about 80%, around about 80% of households that are now classified correctly with the additional data and the corrections to the model that we used. But what really changed the quality of this prediction model here, classification model, is this appeals mechanism. And that is something that has also been shown in the literature. Using that information, introducing appeals mechanism will allow us to introduce equity. Now, in a case where we're talking about contributory schemes, of course, we need to be aware of the different incentives that there are to provide, specific information that might bias and contradict the information that we already have. So that is just something to be aware of and how it worked out in our case. And maybe with that, I want to conclude with some high-level takeaways here that are really just about, generally speaking, PMT approaches tend to lead to significant inclusion-exclusion error. That's nothing new. We know we need to deal with that. But what is important is that those are disadvantaging the lowest income households, and we need to be very careful, in particular when we're trying to use social register data for contributory schemes. Because these models differ so much, it makes a huge difference. And conventional approaches likely won't get us very far if we're trying to design contributory schemes. Our focus here, as I said, was on mitigating model bias, ensuring that the contributions for low-income households are as fair as they can be, not on optimizing overall contributions or model precision. So, if I'm a policy designer, there's a cost involved in this, because what we're doing here is that we're reducing the cost for low-income households while we're not increasing the cost for high-income households. So there will be, general financing questions coming as a result. And second last point is really, even with moderate investments in like further model tweaks, being really careful, using additional information, we were unable to get to 100% model accuracy, even though we see massive improvements in taking a different approach than the conventional simple PMT model. And the last one is really, as I said before, we saw in the data, this appeals mechanism that allows citizens to contest the distributions that are determined by the model, allowed us to further improve on equity, and is definitely something that we would love to see included in such policies. Now, how things worked out in Kenya, we don't quite know. We weren't involved all the way through. Some of these results were very contentious, and therefore, happy to discuss that more. I think we have someone familiar also with the context very much. So with that, thank you so much. I'm happy to take questions.
Thank you for the presentation. I really enjoyed it. I guess the thing that comes to mind and something I'm quite curious about now is you said you did a follow-up survey to get additional data to especially amongst the poor, to help you differentiate and discriminate between different levels of the poor. I was just curious, what were the what were the things that helped you differentiate between people who are amongst, of the poor people? What were the factors that you could use to discriminate amongst them?
Thank you very much. Quite interested in this work. Again, like I discussed with you earlier about the high inclusion and exclusion error. But I just wanted to, because after adjusting the model, taking into account the low-income categories, that is post-hoc and post-appeal, I saw that the prediction was very high, close to 100%, even though the objective was to have 100%. Now, I hope the tricks that you did in the post-hoc and also following contestation is not also overly estimating the level of poverty among the income group. Now, I'm saying this because if you use this model in the Gambia, for instance, we have a social health insurance program, which is largely contributory and non-contributory, particularly for some categories of population that will be subsidized by tax funded. But I'm just thinking that I hope the effort to increase fairness and equity is also not leading to overestimation. And if that is a possibility, how do you also control this? And in the Gambia, we are at a stage where we're thinking of introducing premium for formal sector workers, informal sector workers, and those that are self-employed. Likely, we're relying on some population willingness to pay estimates. So maybe some perspectives on maybe what Gambia can do to improve, premium decision making.
Okay, thank you very much. Very interesting presentation. Just wondering with regard to the validation of the model, if you, there is a process of validating, with the community, looking at the reality, what really, what is the situation. And I think one of the questions I wanted to ask as well, the investment that is required to have this. Maybe it's linked to some specific, social protection intervention, but not really, because some intervention really target the poorest group, and when with the PMT we have the group poor, and the exclusion and inclusion can be a little bit, minimized because of the fact that we are targeting that specific group. But anyway, there is a reason why as well we are targeting that group, because linking that to the fact that there is a high probability of having a very low consumption when you are in that group. But what I'm seeing here as well, you can have some bias. And understanding as well, and this is another element that sometimes we face is, okay, some indicators like consumption are kind of very seasonal and can be affected by, the situation or the data point. So, and really think how your model can help as well to minimize that, because why we think PMT sometimes can be very robust and useful, because if you link your targeting to the consumption, the bias even is really partly in terms of inclusion or exclusion, you understand, depending on the point of time of your data. So that's what I wanted to add. Thank you so much for the presentation.
Yes, good afternoon. Thank you very much for your excellent presentations. My name is William Yada. I work with the National Social Protection Agency. I was particularly interested in knowing, based on the PMT model that you use in Kenya, I would be interested to know, for example, the parameters that you use to rank the population into various income groups. Thank you.
Yes, but physical disability, disabilities in general. But there is a caveat there. The disability that inhibits those people from economic activity. Those are the categories. Because we know there are people with disabilities, but they're still in formal sector, for instance. So specifically, we are looking at those that, whose physical disabilities inhibit their economic activities. So those are people that will be exempted. So in terms of the next step, I think just to wrap up, and then my colleagues can check in. I think what is fundamentally clear is the world has changed. We can no longer rely on external funding to fund our health system. The reason why we are having shortages, the reason why NHIS is unable to expand, the reason why, it's because we are relying a lot on external partners. I think we need to have that national dialogue to see how we can prioritize domestic revenue mobilization. There are good signs because the GRA is gradually digitizing the tax administration, and on a monthly basis you can see record revenue collection. It's also about instituting strong public financial management practices, also accountability for public funds, so that there is that trust and then judicious utilization of those resources. Hopefully with that and more commitment. Of course, Gambia would still require the external partners to support because it's a low-income country, but definitely the focus would be how do we prioritize domestic revenue mobilization. I think that's the only way to go. People are blaming US, for instance, government for all this, what is happening. But what we are also seeing is even within the NATO countries, they are now increasing their defense spending to meet at least 5% of GDP. We are also seeing a reduction in official development assistance. So all those signs are there, and this will they are not going to be reversed anytime soon. So all efforts should be put on board so that we can mobilize domestic resources, so that we can expand the fiscal space for all the key sectors, including health, so we can move on. Thank you.
Yeah, to also support a response to few of the comments that she has mentioned. I must say that I had an earlier panel discussion, and the issue is on people living with disability. And one of the recommendations is disability compliant budgeting. Today we had a deliberate discussion around that, and then I must say that we made some commitment. Previously you used to have the deputy CMD is here. I don't know whether their hospital have trained, how do you call them, sign language interpreters, but it must be integrated into our health sector. Because he has mentioned one of the very crucial questions. How are they taking care? And we've had some of those issues coming up. And I think the ministry should also try to either train their own staff as sign language interpreters or hire sign language interpreters who will be interpreting, within not only the hospital, but I think the entire government should have people that can interpret sign language within. Previously, we used to have social workers in the hospital. CMDs here, maybe they can clarify that. Those social workers, I think, also support people living with disability and other people living with hardship in terms of counseling them to be able to stabilize and also access healthcare. But really, as a health sector, I know this budget has passed, but if you have a second opportunity at the assembly, we will advocate for people, for people with disability, they call them. And also, if it's not possible this year, hopefully next year, we make sure we mainstream disability into the health sector budget. Thank you.
You okay? Yeah. Okay. These are great comments. I think that is maybe an interesting point to stop. I wanted to hear your concluding thoughts as well, if you have, in terms of how can we come together, continue this as a dialogue, less as a debate. Maybe you have thoughts on that in particular? Yes.
So I think having this panel is very important, because the way to go in healthcare is to have it sustained, is to have it accessible, and most important, affordable. But while that is going on, one thing must never be forgotten. That is giving a reliable and up-to-date medical practice in the country. So otherwise, you will provide services, but they will not be up to standards, and then you'll find your citizens or your people going across the borders. And then I know it's an open secret that a lot of people who can't will say, I'm going to Senegal. And then we don't want to do what Senegal is doing. And then in Senegal, if you are a pregnant woman, or if you need surgery, when you go, the first thing you are given is the ordinary items for surgery. You go and buy and bring. And then a surgery that would cost in Senegal $250,000. You come to us, we do it, and then it was costing $2,000. And then now we have increased our services. Now it's costing $400. And then those consumables that are being used, I am now seeing it here as DCMD. 99% of those ones are provided by the hospital. So we are thinking outside the box. For example, you would have seen in the news. So now we have subscribed to what is called MAP, Medicine for All, Pfizer, and then there are also direct aid. So we are able to get these donated drugs into the country. We pay for like shipment. For example, one of the drugs, like Sivo, one ampoule is $7,500. And then now in the box you have 2,000, that's $20 million. So when we receive that, we give to other hospitals, of course. So that one out. So MAP now is coming next month. So we have the gloves that would cost us every 3 weeks, almost $500,000. We have the amount of gloves there that would take us 3 to 4 months. So these are some of the strategies we are going to bridge the gap as a teaching hospital, because this is what we must do, because we have the capacity to do that. So now working with social protection and insurance, so I think, as my colleague said, it should be that triangular. So social protection, we are utilizing it very well. That's why I say it's one of our flagship. Because what we have done with them is to have like 10 tablets where we give it strategically. If a patient comes to us and then now say, I cannot do the lab, for example, full blood count would cost $300. You go across, would cost $600 to $900. And then, because we are not there to make profit, we are there to sustain our services. So that, but when you come and our MRI 7,000, you say, I don't even have food to eat. We'll say, okay. Then we will now look into the system, because they have developed a very robust system. That's the good thing with social protection. And then I think we should all be proud of that. And then all of us are in that system. So when they log you in, they're able to tell us, we are able to know if this person is meet the criteria or not. If the person meets the criteria, we give our exemption form. You go around the hospital, you get all our services. But at the end of the day, we build social protection. They reimburse us. And this is the type of activity we want to have in the National Health Insurance Scheme. And then that is working for now. We pray they have more money to reimburse us. And in that way, we'll be able to sustain our services so that no Gambian or nobody living in the Gambia will leave the source of this land because you can't get a standard healthcare. And then we are there, a lot of things are happening between the four walls of the hospital, and then we can't advert ourselves, but we can tell you that now, if your kidneys are failing or have failed, you can have a top-notch dialysis activity. The consumable, one person, you need $38 to run a session. So now we are working with partners to get us 1 year, and the government is working very hard to sustain it, but we all know, however we do, we have to be realistic. These things are not sustainable, so we have to think outside the box. So now, in terms of surgery, we are there. One of the things that we are not doing here, I would say, would be transplant surgeries, and then also open heart surgeries and some of those ones. And all the plans are there. And while Farako is kicking in, we are putting up plans to take care of our emergency services so that nobody dies because you come emergently, you are able to be taken care of. But all these things should happen at the backdrop of very good sustained system, and it must be well financed. That is where social protection should kick in. That's where our national health insurance should kick in to help that tertiary institution that spends millions of dollars every month to be able to be up and running. So this is what I would say as a conclusion. Thank you.
Thank you so much. That was a very passionate plenary for what comprehensive coverage is looking like at a small scale, could be looking at a universal scale. I want to thank the panelists. I want to close the discussion now for a very honest debate, for raising very important points. I think we all get a glimpse into the ongoing conversations that there are, the coordination that is required in further operationalizing this framework, the big questions around financing and sustainability on the way to having an inclusive, comprehensive, equitable, and affordable healthcare system. So, yeah, thank you so much. Thank you so much for the questions from the audience and the discussion.
This brings us to the end of day 2. It was indeed an interesting session with people from different countries. We have really learned a lot, and we hope the viewers too learned a lot. Do follow Jungle Online TV on all our social media handles. We're on YouTube, Facebook, Instagram, and Twitter. Do also subscribe, because that is what also motivates us to work more. And bye.